So I'm going to move to the next issue, which is extrapolation, another much misunderstood issue. So by way of introduction, extrapolation is the use of a product for more than one indication, but for a biosimilar when the studies are limited to other than complete clinical studies in every indication. Now, it's the same as comparability, where you have, if you make the same molecule, ultimately it has to do the same thing clinically in all the indications. So I think what's confused this debate a lot is people assuming it's extrapolation between indications that may be fundamentally different diseases. So I just want to clarify it's not. It's the same molecule, has to do the same thing as the reference did, as the pre-manufacturing change did. But it does mean we have more limited clinical data sets specific to the biosimilar on the day the biosimilar is launched. Physicians are used to seeing clinical studies on each indication at the day of approval and launch of an originator product. So maybe to our physician, how much is this misunderstanding based on the molecular match being the basis of extrapolation, how much is that confounding biosimilar uptake if there's no specific clinical studies on the biosimilar available to put in front of the physician?
So I want to answer in a couple of different ways. First of all, extrapolation is something that's very important, that FDA kind of grants that designation to a drug when it's approved, or maybe FDA can play an important role in helping physicians understand what extrapolation is. And second thing is, in oncology, if you trace back the history of how we use drugs, a lot of time we may not have phase 3 randomized control studies in all the indications that we use. We initially, before NCCN came into the existence, we used to use compendia listing for indications that were not part of the FDA approved indication. Subsequently, with NCCN establishing a robust pipeline of evaluating, analyzing, and granting the status like 1A, 1B, or 2A, we are very comfortable that even if the drug has not undergone all clinical trials in all the indications, if it comes into the guidelines, whether they are the ASCO, ASH, or NCCN up to 2A, we would feel very comfortable using the drug in those in those categories. Now, what FDA could do is help understand physicians about how extrapolation is kind of derived and how it probably would be helpful. Also, getting into the NCCN or ASCO or other guidelines would help product get appropriate payer coverage, because we just don't need to kind of look at the approval process. We also want to look at are the payers going to cover that or not. So I think extrapolation is very important part of educational piece that need to be highlighted, and FDA would be the most competent authority to do that in conjunction with not-for-profit educational forums.